Rapiscan is used as a stress agent for myocardial perfusion imaging.
Myocardial perfusion imaging is an imaging procedure during which the circulatory disorder or infarction is displayed as an image. And in accordance with the current guidelines of the European Society of Cardiology, and these are fully in force, the old stress ECG should now no longer, or practically never, be used to diagnose a circulatory disorder of the heart. Instead, an imaging method should be used. There are 3 different imaging methods. The simplest, I would say, is stress echocardiography, or an ultrasound during stress. The stress can be physical or also pharmacological. The alternative to this is myocardial perfusion imaging, and then there is the somewhat more complex magnetic resonance imaging, which also uses a pharmacological stress.
Rapiscan as a so-called stress agent in myocardial perfusion imaging includes the following benefits.
There are a whole series of advantages. Firstly, for the assisting staff, who are really pleased. When they saw it, they immediately switched from adenosine to Rapiscan. Why? First of all, they don't have to prepare an infusion pump. This can simply be injected manually, and unlike with adenosine, it's not necessary to individually calculate the dose according to body weight and so on, each time. It is simply drawn up into the syringe and injected. So that is a major simplification. With regard to the patients, one overriding difference is the fact that the contraindications for adenosine, COPD chronic obstructive pulmonary diseases, or bronchial asthma do not exist here. We have now gathered experience with over 5,800 patients. More than 600 of these had a documented case of one of these severe lung diseases, and not a single patient presented any complications. So this is a really fantastic aspect.
In principle, the examination can be carried out on the majority of patients. However, there are a few contraindications that should be taken into account.
If you read the instructions for use, a whole series of contraindications are listed, but in actual fact, these play almost no role in daily practice, because they simply don't come into question. It refers to 2nd degree and 3rd degree AV block, but these are patients who do not belong in myocardial perfusion imaging and who should be properly examined and potentially receive pacemaker implants. Then it says hypotension. Well, that shouldn't be examined with regadenoson either, or unstable angina. These are also patients who don't belong in myocardial perfusion imaging. They belong in the heart catheter department. To sum up, these examinations really can be carried out on the majority of patients.
When preparing the patient for the examination with Rapiscan, several rules need to be observed with regard to food intake directly before the examination.
The preparation for the regadenoson perfusion imaging is quite extensive for the patient. He should avoid eating breakfast if at all possible and should be nil by mouth for the 3 hours beforehand. Some say that a bit of breakfast is allowed, but then the question is, what is a bit of breakfast? So it's better to have no breakfast at all. 12 hours beforehand, so it's quite a long period of time, no coffee and especially no tea. No matter whether it's green tea or black tea, and no cola, and especially no chocolate. Patients can't drink or eat chocolate because this might distort the examination results. So it could show up as a normal result that otherwise would not have been normal at all. And of course, we also say no energy drinks.
When preparing patients, the nursing staff should note that patients need to stop taking the following medicines.
Any respiratory medications at all, since these often contain substances that counteract regadenoson. So if the patient takes any kind of respiratory medication, he should consult us beforehand. And there are medicines that contain dipyridamole. It's relatively rare, but you should take a good look at the drug list beforehand. And ideally, avoid taking cold and flu medicines too. This concerns some cough syrups in particular. So what's important is that the patient talks to the doctor beforehand about what he can or cannot take.
Vein access is secured before injecting Rapiscan. Several precautions must be taken when positioning the patient.
As we know, regadenoson is a vasodilator, and it may well occur since this is a side effect that blood pressure drops and the heart rate rises. And when you inject something that may cause the blood pressure to drop, which it often does, you need to make sure the patient isn't standing. The patient could get dizzy or begin to sweat. This is why we lie the patients in a semi-reclined position. In case the blood pressure does drop, or in case more serious side effects occur. They are very rare, but dangerous cardiac arrhythmias really can occur from time to time. As I said, extremely uncommon. With us, it's less than 1 in 1,000. Then it's better if the patient is already lying down, or at least semi-reclined, than having to suddenly lay him down somewhere, or he might even fall down. So we don't administer the injection with the patient standing. Rapiscan is a vasodilator, similar to adenosine or dipyridamole, which was used a long time ago. This means the blood vessels of the heart are expanded, but where there are constrictions, the vessels cannot be expanded. The vessels remain constricted here, and the Rapiscan causes a difference in blood flow. This means that in the normal, well-perfused areas, a lot of technetium goes in, and in the badly perfused areas, not much technetium enters. And this difference is then displayed as an image and registered as ischemia or as an infarction.
The heart and blood pressure are monitored throughout the entire examination. After the patient has been correctly positioned, the Rapiscan is injected. The dose consists of a single injection of 400 micrograms of regadenoson in a 5 milliliter solution. The injection is not based on the patient's body weight. In order to avoid side effects, it is important that the Rapiscan is injected over a full 10 seconds. The patient will also receive an injection of saline solution. Lastly, a small dose of MyoView is injected.
As mentioned, regadenoson is a vasoactive substance, meaning it is a substance that has an effect on the cardiovascular system. This is why we administer it, and in rare cases, there is a definite possibility that we will see a drop in blood pressure or that bradycardia will occur. Asystole is also possible. This was actually more common with adenosine, so you do need to be prepared, and the classic antidote is aminophylline, as mentioned in the descriptions. However, this antidote is only available in tablet form in Germany, rather than as an injection, which is why we keep theophylline, which has a similar effect on hand. What is also very important, in particular if bradycardia or higher degree AV blocks occur, which is very rare, but you have to be prepared, then we also have atropine at hand. Severe complications are extremely rare, below 1 in 1,000, and this tiny percentage that we did experience were 2 patients with asystole, so actual cardiac arrest, both successfully treated with theophylline and atropine intravenously, and in need of resuscitation to some degree. Similarly, in the region of less than 1 in 1,000, second or third degree AV blocks may also intermittently occur. Extreme bradycardia, heart rate of less than 40, and with 2 patients, we did observe an epileptic seizure. But you have to know it's incredibly rare, but it can happen.
The patients are further monitored for about 10 minutes following the injection.
We observe the patient for 10 minutes after the injection, which means taking their blood pressure, ECG heart rate measurement. So the ECG measurement remains on the monitor, and after 10 minutes, the patient then goes under the gamma camera.
Let's turn the ECG off again. Now it can all come off. Now I'll take the ECG electrodes off you. So, now you can get up, take your things and come upstairs with me. The needle will remain in there until the examination is finished, until the images are complete. Now the chair will go backwards, the camera will come towards you, and I'll attach another ECG. I'll be back in 12 minutes. Then you may get up again. So, now I'll take the needle back out.
Well, first we take a look at the images to see if they've come out okay. This is very important. If the patient shifted or coughed or turned around, then we might have to do it again. And what does occur from time to time, it's uncommon, but sometimes it simply happens, that we observe considerable gastrointestinal activity with the technetium. And if that is the case, evaluating the image becomes a bit more difficult or not so reliable. And then we tell the patient to eat a soft pretzel or something similar, or just to eat something and then get under the camera once again. Naturally, we then discuss the findings with the patient.